Please join me in welcoming Dr. Cronenwett as she presents strategies for building a quality and safety culture.
Thank you, Lynn. Very nice. You can't imagine how wonderful it is to be here. When I was in the whiteout this morning on the drive-in, I thought, will I see your bright and shining faces tonight? And I'm so glad. This is my first ever visit to Villanova, though I've known many of your faculty and certainly your dean for many years, so it's an incredible privilege. I am talking tonight about a topic that does mean a lot to me, and I recognize the breadth of the expertise in the room, the faculty here who have worked very hard on this topic within your own university. And I look forward to the time when we can have conversation at the end of my remarks. I also welcome, if anyone wants to come to the mic in the middle, that's fine too. Sometimes it's more fun to do it on the spot, and I'm certainly open to that if you would like to do that as well. So I'm going to focus tonight on this set of topics, sort of where we've been, where we are now, what is this about safety cultures, and then what is our role, what's your role, each of you, as well as my own, in building this into our healthcare system. I suspect most of you have been in a hospital or had a loved one in a hospital recently, and would anyone be willing to share if they've had a concern about safety or quality of their loved one? Is that something you've experienced? To raise your hand if that's the case. Not so much? Some, the older people. Yes, maybe not so much the younger ones. We have faced somewhat of a crisis for ourselves, and it becomes a crisis because of this theoretical background. I think that most of you who are coming into nursing here come into it because you want to help people, and of course you are learning to be a nurse because you want to deliver good quality and safe care, and that this quality is an essential value. In fact, we know that when people work in systems where they don't think the quality is very good, their own morale erodes, and you get people leaving the profession during periods like that. And so we know there's this connection between our professional joy in work and the quality of what we do out there in the world. And we believe, our assumption is, given the multitude of errors that are going on at the moment in our systems, that we actually will and can find joy in improving these systems if we have the culture and the leadership and the support to do that. So that's our assumptions. But just so, for those of you who might not know the literature on this topic, we have been faced with the fact that there are incredible sources of error in our system. Unlike aviation, which years ago began to do the hard work necessary to make it a high reliability organization, that is not something we've done in healthcare until more recently. And we still have, as these headlines show you, some issues of people being injured in the course of their care, deaths due to medical errors, and yet we also have people reporting on the reduction in harm that they're being able to do. In North Carolina, we have a quality center where we follow 116 hospitals in North Carolina, Virginia. We work together to try to bring down the harm from a variety of things. And this was just at our board meeting a few weeks ago. We got the progress to date on a couple years of trying to work on these. And you won't know all these acronyms, but you can see that we really could bring down elective deliveries that are occurring prior to the time. People are being induced before it's really safe to induce them. We've been able to decrease that. We've been able to decrease falls across these 116 hospitals. Central line associated bloodstream infections, doing pretty well. Adverse drug events, doing pretty well. Ventilator associated pneumonia, pressure ulcers, that you can see. And then you look at the one on the other end, CAUTI, the catheter associated urinary tract infections, just can't get a handle on that in our systems. If any of you are in systems where you're doing this, I'd sure love to hear about it because we're not going in the right direction on trying to reduce harm from catheter-associated urinary tract infections. And I was just at University of Virginia a couple weeks ago, and that's their healthcare system's #1 issue they're focusing on this year. And we'll see if anybody can manage to conquer this. But again, just to reinforce the point that if you look at the leading causes of death in the United States, you can see where preventable medical errors come in. This is not a small, insignificant problem. It's a pervasive aspect of our systems of care at this point in time. And it's not from people intending to do harm. It's from systems that just aren't high reliability, high quality, high safety systems. So, given that, we have the evidence of harm, we have the evidence of lack of reliability in our processes of care. We have a lot of evidence about what are best practices in the country. We have lots of data now so that we know who's doing well and who's not doing so well. We have financial incentives. For the first time, our hospitals are not being reimbursed for care that falls outside of some of these quality and safety guidelines. We have a national quality strategy. We have patients and consumers who are activated in groups. And we have our own health professional licensure, certification, and accreditation standards built into them, requirements that we address this issue. So there's tons of pressure, of calling to each of us to make a difference. But why? So we're trying to go in this direction. These are some of the goals we have in North Carolina and Virginia: reducing harm, increasing reliability, making sure we have patients and families engaged as partners, promoting effective communication and coordination, and furthermore, making quality care more affordable, because the issue of affordability is huge in our country right now. And unless we bring that whole value equation into perspective, we won't make progress on quality and safety. So what's the issue for us? We have, when you're coming into a profession like ours, and any health profession, or hospital administration, any field that affects the healthcare enterprise, we're all being called to hold 3 large aims together. We want patients and communities to have better outcomes of care. We want systems to have better performance, and we want better professional formation and development of our young, new professionals. And by and large, what tends to happen is one group of people in a profession, by and large the practitioners, concern themselves with the better outcomes of care. And one group of people, the administrators, concern themselves with system performance, and faculties tend to concern themselves with professional formation and development. And what we're realizing is, unless we all concern ourselves with all 3 of these circles, we're not going to make progress. We tend to do this in isolation, and we don't have the benefit of the synergy that would come from all of us doing this together. And we'll come back to this a little bit more at the end. Paul Batalden is a pediatrician who was one of the early thought leaders in the quality improvement movement. And if we're talking about preparing health professionals, the point, I think he makes it very well. We're trying to prepare you as a part of your normal professional development to lead the continual improvement of quality and safety and value of healthcare. You say, maybe, why me? I just want to be a nurse. But the why me is, there's nobody else out there. It is nurses and physicians and hospital administrators and pharmacists. And we are the people running the healthcare systems. We are the people leading at the front lines of care, in the middle managements of care, at the tops of the systems. If we don't do it, there's no one else out there to do it. So we want you to be prepared to do this as a part of your normal professional development. And what that means is that you ought to be able to know how to identify good care from the scientific evidence, and I'm sure that your faculties are preparing you very well for that here. to know the actual measured performance in the context where you're learning or practicing, and the gaps, if any, between what's known to be best practice and what that local care is. And I would wager from all these years in QSEN that there are probably 95% of the students who don't know that when they go into a clinical area, that we, the faculties, don't tend to help them become aware of that. That for many years, our physicians and nurses had no idea how well they were doing against any standard whatsoever. We all thought we were delivering good care because we all thought good quality care was a property of the individual professional. If we memorized our things and we knew what to do and we learned everything we could and we were always careful, then there would be good quality, safe care. And the thing of it is, that simply isn't true. One of the nurses at Dartmouth, when we were starting this, said to me, you know, if your mother's in the hospital, you want me taking care of her because I'm the best nurse on this unit. But don't bother me with having to work on anything with my colleagues because I hate that. And we want you to graduate never thinking that's the best nurse, because my mother will not get good care if that's the best nurse. Because unless every other person who touches my mother has the same reliability and the same safety, unless there's some peer accountability, unless the systems are set up to reinforce safety and quality, unless something about that system has figured out how to be reliable 24/7, my mother is not going to get good care, no matter how good that individual professional thinks he or she is. So, we want to be graduating you at every level of our programs, knowing that you're going to know because you care, because part of being professional is knowing how well you're doing. Not just that you thought you did everything right today, but actually you know that the care on this unit is good, that your catheter-associated urinary tract infections are here, and they should be here, and this is what you're trying to do about them, or whatever. And then finally, to know what you would do if there are any gaps between best practice and what you're experiencing on the unit in which you're in. If every professional graduates feeling that's a part of their work, we have a much better chance of having high reliability systems. So what do we need to change? We need to be inviting. You will spend a lot of time, and your faculties have to make sure you as an individual know how to give care and what's important. I'm not saying that's not important, but we've focused 98% of our attention on that for years. And now we're trying to expand that focus a little bit so that you always keep the patient experience of care the primary focus, so that you always understand and apply the basics of the safety sciences that I, for one, never learned as a student, that you adhere to evidence-based standards and guidelines or know why you're not, and that you embrace that continuous quality improvement in your microsystem and in your practice is a part of your daily work. Mary Delansky at Case Western Reserve has taken over the leadership of QSEN in my moving towards retirement. And she and Shirley Moore have, I think, a wonderful point to make in this image, which is that we need both vigilant individual care and we need vigilant systems of care. And only when we have both of them do we get optimal patient care. And just again, for the students in the audience, to just make this point one more time, they have a scale that they have developed about systems thinking so that they could evaluate whether students were where they were on a continuum. And this is sort of the example we're talking about. You know, the nurse who always turns the patient when they're supposed to. That they know you're supposed to turn the patient and they do it. The nurse who might post a note above the bed to remind others because it hasn't been getting done reliably. The nurse who will ask about new products maybe to prevent pressure ulcers. The nurse who might look at the ulcer rate on the unit and know what it is. The nurse who might compare that ulcer rate with benchmarks. And then I would add that the nurse would be willing to work to improve their unit's ulcer rate. I'd ask you to think about where you feel like you are on this continuum of systems thinking at the moment, and we'll come back to this step at the end of my speech as well. For all sorts of issues like this, we are in many different places. And it's the issue of moving us along this continuum that we're talking about tonight. So from the safety culture literature, we know that high reliability organizations consistently minimize adverse events despite carrying out intrinsically complex and hazardous work. And we are part of that. We work in systems that are intrinsically complex, very complex, that require incredible communication in order for patients to get good care. And that's hazardous, that it has equipment changing all the time, multiple forms of equipment. I mean, those of us who've been in this a little longer, there was a period when we were beginning the cost control where they were switching our equipment every 2 months to get a cheaper version. Well, you couldn't possibly get safe on that and have 100% of your nurses safe on those pieces of equipment when they were turning over all the time. It's highly complex and hazardous work. And the other thing is that it's always fundamentally a local problem. It is not something that the CEO of a system can stand up and say, we are safety. It's what's happening on this microsystem, this unit tonight on the midnight shift. It's not, it's just fundamentally has to happen all the time, everywhere. And we had at Dartmouth, when we started looking at our data, we had incredible variability. And we considered ourselves a high-quality hospital, but we had tremendous variability from one microsystem to another in terms of its reliability and its safety culture. You can, I know that some of your faculties may have been visitors in magnet institutions, and you can also find very good safety culture things going on at high-level management and not much at all at the front line, and vice versa. If there was ever a time and a place and a topic about which it is so clear that you need leaders at the front, leaders in the middle, and leaders at the top, and they all have to be doing something, they all have a role to play in this, creating a safety culture is one of those. That's a perfect example. Organizational leadership has to be deeply involved. They have to know what the issues are that their frontline workers are facing, and they have to understand the established norms and that hidden culture that often guide behavior. One of the biggest issues we're having in teaching you, younger people, about this topic in the course of your education is we're sending you into microsystems all the time where you're getting clinical practice, and you may not see these things in action at all. And that hidden curriculum, which is what you see, what are you supposed to believe? That that's how I'm supposed to behave, or this is how I'm supposed to behave? We have to bring those cultures together. And the safety cultures are also highly dependent on how all the professions work together, how everyone involved works together. Always at a microsystem level. So these are from the ARC, the Agency for Healthcare Research and Quality website. You know, you can go there and read about safety cultures, how to measure them, all those kinds of things. But these are some of the key features of those. An acknowledgement of the high-risk nature, a blame-free environment where individuals are able to report errors or near misses without fear of reprimand or punishment. It doesn't mean it's not a just culture. That is, if people willingly and consciously take risks, that they might be punished for that. But for the multitude, the bulk of errors that are made in our system are issues for which the system is as responsible as we are. And it's the pressures of productivity, the pressures of families, the pressures of communication, all sorts of pressures that bear on an individual who makes an error. And we need the errors to be reported in order to learn how to prevent them, and that can only occur in a blame-free environment. We've had a lot of work in the QSEN about what do schools of nursing do, and how do students feel about reporting errors. Very important issue. When we started doing the work at QSEN at UNC, one of the faculty at my place had students in the clinical area, and they were passing meds that day, and they got to the bedside, and the family said, "No, you're about to make an error." And the faculty member said, "If I hadn't just been in those QSEN things, I would have said, 'What do you mean? I know, I supervise this. This is right.'" And she said, "Instead, I thought to say, thank you. Thank you. You're being my partner in preventing this error." And it was outside the 20 minutes that was supposed to be given, so there was some validity to it, even though it wasn't probably a risk of harm at that point. But the blame-free environment has to be for patients and families, it has to be for the frontline caregivers, it has to be for our students, it has to be for everyone so we can learn. The encouragement of collaboration across ranks and disciplines in order to seek. Everyone has to be able to call the question, stop the process. There can be no captain of the ship. You can't criticize the captain of the ship. No, you have to have a culture where everyone can criticize. You have to have someone willing. I don't know if any of you have ever heard the aviation story of I can't remember which airline it was now, but one of the major big crashes that led to the aviation work occurred when the pilot of that plane was the chief quality officer of that airline. And they realized that it wasn't just a property of the individual, it was a property of that system. Those navigators had been afraid to say to that pilot, "It's too late, we're going to missed the mark, we shouldn't be going up in this weather." I can't remember what it was, but they were afraid of him. And the culture was you didn't question the captain, and he was the VP for quality, and they crashed. So this collaboration and all seeking it together, and then organizational commitment of resources to address concerns. So these are some features of them. So I want to talk a bit about if we're trying to do these lofty things, why aren't we? We have been trying for 10 years now, since the two eras human, and we are making progress, but we are not making progress fast enough, either in the preparation of new health professionals, in the practitioners who are trying to work on patient outcomes, or in the administrators who are trying to work on system performance. And I think it's always good to ask ourselves, is it an issue of will? Is it an issue of that I just don't have any ideas about how to go about this? Or is it, yes, I know I'm supposed to and I have the ideas, but there's just not time, I'm not willing to put in the effort of execution, what is that about? So I want to take each of the 6 QSEN competencies that we talked about and sort of say, what do I think some of the gaps that we're experiencing are? And let's start with patient-centered care. And I'm not going to read the definition of that competency because, you probably have had it in your coursework, or will. But I think that our cutting edge on this competency is that if we're going to do patient-centered care, which nurses have felt we owned for centuries, literally, and by and large we are patient-centered, but in this day and age, in the environments we're in, you can't be this version of patient-centered without knowing the patient's values and preferences, and sometimes it's very hard in our systems to find that moment of connection to actually know what those are. We need this issue of welcoming patients and families. I spent my whole life, might have written the first paper on fathers in the delivery room, because when I was a young nurse, we didn't let them in, right? You men in the room, you probably can't even imagine that, but we didn't, because what? They would faint, they would whatever. We have not welcomed family members. Then we kept them out of the ICUs, and we kept them out of the ERs, and we kept family members away. At Dartmouth, we always allowed staff to be in the PACU when their loved one woke up, but we wouldn't let anybody else. Why? If loved ones want to wake up and see their loved one's face instead of just a bunch of equipment, why wouldn't they be able to? So we've spent a lot of time not actually in our systems of care welcoming people in, and I think that's still a cutting edge for us. It's still in hospitals in my area, in North Carolina, we still hear nurses say, well, the families would just be too much trouble, or, well, then I would have to monitor this, and all of that. But the thing of it is, right now, if we can't promise people that we can keep them safe in our complex systems, what ethical basis do we have to say they can't have a loved one sitting next to them all the time they're in our place? We have no ethical basis for that. If it causes you more work, we learn how to do that. That's what we need to learn to do. They need to be our top priority, not our schedules and our timelines and the way routines that we want to set up. They need to be it. And we have to figure out how to help them get their very complex care given by hundreds of people sometimes if they're in the hospital for 3 days, how to get that coordinated. Teamwork and collaboration is the second one. We spent a lot of time in all the years I've been in nursing education teaching people about the nursing team. And what we realized when we started QSEN is that by and large, 90% or more of nursing students would graduate from nursing school never having had a meaningful interaction with a physician. The person they would work with the rest of their lives. How were they supposed to have figured out how to work well together if they've never even had a meaningful interaction? And so we're doing a lot of work in the country on trying to build interprofessional experiences early on. And I'm sorry I didn't have enough time to find out here what you're doing with respect to that, but we need to think about team writ larger than the nursing team. We need training in team and team-based care, and we've learned a lot from aviation in that, and there are great resources in ARC for team steps, et cetera, if you're trying to teach that. And we've done that with the nursing medical students at UNC and Duke, and we actually compared. We put them in different scenarios. Some only listened to a lecture, and some had computer simulations, and some had low fidelity simulations, and some had case studies, and they talked about them, all with the goal towards learning more about teamwork and collaboration. And actually what we found is that the students enjoyed the more interactive things better, but they all learned. So the message to us was just do anything in this domain and you'll have some gain. Valuing the patient and family members as essential parts of the team is a gap for us, although a lot of you are probably doing patient rounds with family members and doing your handoffs at end of shift there. We obviously need to graduate everyone knowing that almost every healthcare error there has a relationship to some form of communication problem across team members, and we need us to all learn something about ourselves. You know, we all have strengths as team members, and we all have weaknesses. In fact, frequently whatever is your greatest strength is your greatest weakness too. And you need some sort of self-knowledge about that to be a good team member, because you need to know what impact you're having on others as you work together, and you need to be able to work across quite significant authority gradients in our health professions. And you need confidence in that, and that's what we want for you as we move along. Evidence-based practice, as I said, doing quite well on that, approaching practice with a spirit of inquiry, learning about how to identify good care from scientific evidence. Again, early in my career, a faculty member would do one study and then they'd want their students to put that into practice. Now we know that is not evidence-based practice. It's not until you have a lot of studies showing the same thing and you search the literature and you really have sufficient evidence to change practice, generally speaking. We need you always scanning sources of new knowledge and developing the expertise to balance evidence, your own clinical practice and judgment, and what the patient wants. Sometimes we call evidence-based practice and only things that are based on the research, and not the melding of that with what the patient preference and values are. And that's something you can learn from really good clinicians as you go along. Quality improvement, we found just now, it's maybe 7 years ago when we first did the study. But people have replicated it since then. And very few schools are working in the teaching about quality improvement science as a part of their general education. We're getting that more now at the graduate level, a little bit. And whatever's appropriate there, we need people to, at a minimum, have this concept that it's an important part of my daily work, that I'm accountable for the microsystem I practice in. It's not just I'm showing up for my shift. I'm accountable for this practice system. Comparing to others, yes, I've said that, and needing to use quality improvement methods. You can learn about those quality improvement methods sometimes in courses, but in residencies as you go into your first practice site, in quality improvement camps for the staff, all sorts of ways you can learn about that, in graduate programs, whatever. But we need to do a whole lot more improvement on this competency. Safety, minimizing risk of harm. We need to know how to create and support the just cultures and the safety cultures that I talked about, how to learn from open reporting. We're getting a lot more cooperation from our local healthcare facilities in letting our students have access to some of that data, in letting students actually listen to a root cause analysis of a medical error so that you can learn early on about how does that happen. And then just this issue of supporting a culture that holds teammates accountable for reliable attention to safety. Probably the hardest thing we do is hold peers accountable. That's deans holding deans, and faculty holding other faculty, and students holding other students, and staff holding other staff. But I watched it at Dartmouth. There were units where the nurses on that unit, they hired the people, they fired the people. They said, if you want to work on this unit, this is how we behave. This is how we behave with physicians. This is how we behave with patients. Please don't come work with us unless you want to behave this way too. They accepted accountability for creating that system, and they welcomed people who wanted to create it with them. And they held each other accountable for practice. I'm sure many of you are in places now because people are trying to get people to wash hands consistently. Not a high-tech intervention at all, but an incredible intervention that if you watch the data on hand washing go up, you watch the healthcare infections go down. And every hospital can see this. It is a matter of us being accountable for our hand washing. Oh, this was a great example. One of the magnet appraisers told me recently they were at a hospital where the nurses said to them, we accept 200% accountability for our patients. And the appraiser said, well, what does that mean? They said, we accept 100% accountability for ourselves, and we accept 100% of accountability for our peers. That we will call on somebody if we see them not washing their hands, if we see them taking a risky step, if we see them, we will do that because that's what our patients require. So I think those are the places we're going in that. And lastly, informatics. There's no question we're being stressed enormously with the electronic health record for good and for harm. And we need improved EHRs and alert systems. Right now, last week, I think something came out in the paper about a place that documented in a month in an ICU, 2.5 million alarms went off. Well, who can pay attention to that much alarming? No one. We have to have improved technologies to support us, and nurses need to be involved in doing that. And we need to know and try to predict, when we introduce this new technology, what are the harms we're likely to introduce along with it? Where are we going to go? Do that sort of assessment up front. And be involved whenever you can in the design and evaluation of these communication systems, because they are here to stay. They will be here with us. But right now, they're really, really difficult for clinicians. It's impeding workflows in many instances, giving us great data, but still a lot of problems. And we need all of you working along the way with that. So one of the issues is, okay, if you break out each of the competencies, there's still work to do. Another issue is this issue of what do you all see as constituting your daily work? And one of the problems that exists for the people who are leading and managing you is helping you actually incorporate this work into your daily work. Unfortunately, it can look like add-on work. We had, in North Carolina recently, we had where the hospitals come together with their healthcare infection people. And of the people who came to get that meeting, 50% of the nurses were on their vacation time. That's unacceptable. That is unacceptable. That is not part of your daily work if you're coming to do this work on your vacation time, right? We need people in leadership to figure out how to make sure that, yes, people will want to do this work, but they may not want to do it on their vacation time, right? The same thing happens with nurse practitioners or nurses in advanced practice. Sometimes cannot get out of the seeing the patient to do this work unless they do it on weekends or other times. And I can tell you when we started QSEN, which was a movement to try to change curriculum across the country, faculty said too, this is not a part of our daily work. We're here to teach OB. We're here to teach public health. We're here to teach this. We're here to teach that. And that's our daily work, not getting these competencies involved. So all of us have this as an issue. Another set of challenges. We still aren't at a tipping point where new graduates are prepared in these competencies. I think when we get to that tipping point, it'll be really good. Because I watched over 14 years at Dartmouth was when schools decided they were going to teach people about evidence-based practice. And we could see them coming out, the students were coming out differently. And one of the first schools that implemented QSEN from head to toe in their curriculum is now, 7 years out. And that dean reports that when she goes to see employers, they say, what are you doing? Whatever you're doing, we really like. We really want your students. This is what's important. They're coming to us with it. So we'll get there, but we're not quite there yet. This issue of work, not yet re-envisioned to incorporate these new commitments. We have that work to do. This lack of safety culture development in all the microsystems in an organization, every single one, and the lack of patient and family engagement in setting priorities for improvement. It's amazing, and frankly, if I have a nurse or a physician say, well, nobody wants to do improvement work, how can I get them to do it? I might say, ask them what their biggest problem is. Because it's amazing, you can really get nurses and physicians to work on something that's really driving them crazy. But we'll really know we've gotten there if it's what's driving the patients and families crazy that really makes our improvement work go. We aren't yet to the point, although more and more, where QSEN competencies are a part of the hiring. That is, you're being interviewed for what your attitudes are about these. They're not universally yet in your residency programs for new grads. They're not universally yet in job descriptions or performance appraisals, but it's really on an uphill climb and moving quickly across the country. If they're not in these things, it doesn't send a message that they're important. So we have to make sure they're in these things. The peer accountability structures, well, I wish that you students would jot a journal about every microsystem you work with while you're in a school, and think about it from the point of view of these 6 competencies. Where have you seen it really come together? Where have you not? What's the difference? Because you can see it when it's there, and that's what you're going to want to try to create when you're done. And we still don't have it where promotions are tied to expertise. We still don't have it. Sometimes it's still the nurse who's the best clinician, who's the one who wants to take care of my mother, who gets promoted to be the frontline manager, as opposed to the person who has these competencies and is going to make that frontline microsystem have a very high reliability unit. So all these things are still challenges. But as I said, we have some signs of change. We've got lots of efforts to improve teamwork and collaboration, both in academic and in the practice settings. Lots of people doing work on this. You'll run into it sooner rather than later. We have requirements for quality improvement in many states now as a part of advanced practice licensure or recertification. In North Carolina right now, not everyone gets audited, but everyone is at risk for being audited to see what their quality improvement work was in their last year. So the message is you have to be, as a clinician, working on knowing something about your patient population and what you're doing to improve their outcomes. And practice settings are investing more in staff engagements for improvement projects, and many of them on paid time. And I consider that a true marker of change. We're getting, from the faculty side, lots more access, as I mentioned, to QI teams and root cause analyses, et cetera, and letting students be part of that. We have right now, the National Council of State Boards of Nursing has pilot states. There's, some consideration of the idea that maybe we should license nurses when they graduate as a new grad, but you should have to require a relicensure at 1 year, and at the end of that 1 year you would have to prove that you had a certain level of competency development in that first year, and in that program are the QSEN competencies. So we're thinking ahead to making sure it's embedded once you're in practice. And then nurses as leaders and partners in interprofessional teams. Really, I think the older people in the room would all agree that there has never been a time where our participation in interprofessional teams working to improve quality has been so valued, so welcomed, so sought. It's just a marked difference from my early days. I want to take one moment about this issue of, well, how do we lead this? Because you'll be leading this, or not, from the front line, from the middle of an organization, or from the top throughout your life. And I want to just mention this concept about managing polarities, because sometimes we are indeed managing two things that have opposite effects, both of which are important. They're sets of opposites that can't function well independently over time. There's no endpoint. They're unsolvable. There are two legitimate points of view, and both are correct. An example would be organizations thrive on stability, and they thrive on change. They don't thrive on just one of those or the other. They have to be managing that polarity so that you get enough of the good stuff from stability, and so you get enough of the good stuff from change, that your organization thrives and moves forward. And you have to have leaders who are thinking about making sure you don't let stability get so entrenched that you get stagnation or loss of energy, or people just, you miss a bunch of opportunities. And you don't want to get leaders for whom no change ideas is not fun. Let's just change every minute, So this idea of managing stability and change is relevant to the work we're doing. Both sides are important. Most of us, if we were honest with ourselves, have a preference for one side or the other. And the more strongly attached you are to one side, the less likely you are to see its downside. You have to just know that about yourself. You're human. You will make errors, and you're human, and you will have a preference. But you need each other over time in order to sustain both sides. In the Executive Nurse Fellows Program, we actually do a series of assessments on senior nursing leaders that are part of our fellowship say, take the change issue, stability and change. Somebody who doesn't really want to change unless there's a lot of data to show that that's a good idea versus the person who thinks it's great. And we have them line up across the room in a circle from the highest change preference to the highest stability preference. And we have them talk to each other about what it's like to work with each other, which can be painful, right? But if you go into this knowing that you have a preference, that it is a polarity, that both these things are good, it's much easier to work together over time. I don't want you to read every detail of this, but I want, this is a great example that they did on the issues we're facing with implementing technologies when we're preparing professionals who love the interpersonal practice with the patient. Both, in this day and age, are incredibly important. Both have positives, both have downsides. And this group actually took the work of saying, gee, what would be the action steps we'd have to do to really push the positives of technology? What would be the action steps we'd have to do to push the benefits of that practice? What would be the early warning signs that we're really on the downside of technology, and what would be the early warning signs that we're really letting that go? Again, it's not this issue in particular, but if you run into these thorny issues in your practice settings when you're trying to make a microsystem work differently, you might think about, are we trying to manage a polarity where two things are good, where we need both things, and we can really work on making sure everyone then can embrace both things and not be blamed if you're an advocate on one side or the other. And if we did think about things in that way, then I would say, could we automate without dehumanizing better than we do? Could we achieve fiscal soundness without decreasing quality? We have to do both. Could we use evidence-based standardization without losing the individual patient and their preferences? Could we enhance the team without losing the love we each have for being that person with that patient for that death or that birth? And could we innovate without losing our roots in terms of stability? It's a great, great set of work that this Tiger initiative, which is about informatics, did. Could we assure that we developed quality and safety competencies at both the individual and the system level? That they're not, that while they're polarities, it's true, but we all have to be managing both of them, not just one faculty member over there doing the system and the other 95 doing the individual, but that we're all doing both of them. Building in continuous improvement as a part of our daily work is part of that, creating these robust and quality, and safety cultures. Would we have then better outcomes, better system performance, and better health professional formation and development? So I am not speaking to just the nurses who are CNOs in the room. I'm speaking to the nurses who are going to lead on your unit. I have now read about 400 applications to the Executive Nurse Fellows Program. These are senior nursing leaders seeking more leadership development. And Robert Wood Johnson Foundation has funded this program for 20 years. We're very grateful to them for that. But I've read now this many, and I can tell you that they all begin with, I started nursing thinking I was going to do this, and then someone said to me, gee, you really have talent. Why don't you also do this? And then why don't you also, and before I knew it, I was leading this on my unit. I was leading this there. And then someone said you should do this, and then someone said you should do this. And that this serendipitous thing happened, that your leadership existed the day you started, just as it exists later in your life. You will find that. So I offer this to all of you, not just those who are our leaders in the traditional definition of leaders, like deans. I want to invite you to come forward and use this next period of time for questions. But before I do that, I want to return to this idea of Mary Delancey and Shirley Moore's continuum of systems thinking, and think about where you were on that step. And I want to return to the idea of managing polarities and where you are in preferences as it relates to that. I want to return to the idea that instead of being just about patient outcomes or just about system performance or just about professional development, you're thinking about all of them together, and ask you to think about your own self and your role in moving our country's healthcare system to a more reliable place. And so I'll share this poem by David White. Start close in. Don't take the second step or the third. Start with the first thing, close in, the step you don't want to take. Start with the ground you know, the pale ground beneath your feet, your own way of starting the conversation. Start with your own question. Give up on other people's questions. Don't let them smother something simple. To find another voice, follow your own voice. Wait until that voice becomes a private ear listening to another. Start right now. Take a small step you can call your own. Don't follow someone else's heroics. Be humble and focused. Start close in. Don't mistake that other for your own. Start close in. Don't take the second step or the third. Start with the first thing close in, the step that you don't want to take. If we all do that, we move our healthcare system in very, very important ways. And as Nelson Mandela said, this is our time to do right by this issue, and it will only seem impossible until we're done. So thank you very much.